So I'm a neonatologist at Auckland City. There are 8 of us there now, and I think we all have different characteristics and skills that we bring to it, the job, but I think my one is I'm supposed to be the touchy-feely one. I also am a trustee of the Brainwave Trust, which is really about trying to give children in Aotearoa, New Zealand, a better start in life, and by educating people who work with children such as yourselves and parents and lots of preschool people, anybody who a child encounters in their early childhood, about the importance of the neurobiology of how we develop our brains in those first few years in response to our experiences. So I'm going to race through a whole lot of things. It's going to be a bit of a medley, but I'm really happy to stop and for you to ask me questions at any point, and I'll probably cover a little bit of the same stuff that Lindsay did. We'll see. So these are some of the things I'm going to talk about. I'll spend a bit of time on colic and gastro-oesophageal reflux, a bit of time on brain development and development just to get you thinking differently. I want to talk about cerebral palsy because it's always been my impression with parents and with people working in paediatrics that sometimes people have an unusual and now outdated idea of what cerebral palsy is about. And then I'll talk about NAS, which is neonatal abstinence syndrome. If I've got time, plagiocephaly, Aspergers syndrome and ADHD, but I've got about an hour and a half to do that in. So this is the first part of the talk, is going to be about the puking infant. I think a lot of what we know about the puking infant, the unsettled, difficult infant in those first 3 months of life, who does a lot of spewing and crying, and often runs with fashion. You know, it used to be all infantile colic, and now it's all reflux, and I'm just going to try and put you right on some of those things. So just quickly about gastro-oesophageal reflux. That just means that, you know, milk has been in your stomach and it comes back up into your mouth. And virtually every single baby has that. So the spilly condented baby doesn't need to be treatment. And the only time we get concerned, and I'll go into the red flags again, but if they're not gaining weight, they're vomiting up blood, or they're excessively unsettled. Now that's a bit of a bomb, that one. So, and what we do is we prop the babies, we thicken the feeds if it's possible, but most babies are breastfed now, we hope, and that's difficult to do. And there are various drugs, all of for which good evidence is completely lacking, and they may be harmful. And also this business of silent reflux, you know, you either reflux or you don't. If it's silent, that doesn't tell me anything that I don't already know. So from the NICE guidelines, which are the UK guidelines, gastro-oesophageal reflux is not gastro-oesophageal reflux disease. Important to remember that. It affects about 40% of infants, begins before 8 weeks. I would say near 100%, tell you the truth, but there we are. Maybe frequent, like usually, you know, several times in 24 hours, certainly not just once a day. Virtually all of them resolve by a year of age, and that's important in terms of your diagnostic criteria, and it doesn't need investigational treatments. So the red flags for a baby you think might have gastro-oesophageal reflux are if the vomiting is projectile, particularly in those first 8 weeks, because that means they might have pyloric stenosis. But remember, 1 or 2 vomits, projectile vomits, isn't pyloric stenosis. Pyloric stenosis is one of those things that takes a while to work itself into. So these babies have more and more projectile vomiting. And the idea of being able to give the baby a test feed, watch the pylorus, which is the outflow tract of the stomach, contracting, and then a reverse wave of peristalsis and have a vomit all over the floor, is something we don't get to that point very often these days, because these days if a baby has a few projectile vomits, the best way to find out what's going on is just to do an ultrasound of their abdomen, and you'll see very clearly on ultrasound whether or not the pylorus is thickened and muscular. Bile stain vomiting is always a red flag. Blood in the vomitus is always a red flag. Blood in the stool is always a red flag. And of course, in the first few days of life, blood in the stool may simply be swallowed, maternal blood. We need to remember that. And there is a test you can do to test for the APTS test as to whether the blood is adult hemoglobin or fetal hemoglobin. So it's not that difficult to distinguish. If there is excessive abdominal distension and or a mass palpable, I think that's a red flag in a baby who's vomiting. Any other signs of systemic illness, and then persistence beyond a year of age. Well, you might say, well, a lot of those things are sort of vague, but I think bile in the vomit, blood in the vomit, that's pretty easy to, think, well, that's serious. So I'm just going to talk briefly about proton pump inhibitors, of which the classic one is Losec, but also histamine H2 receptor antagonists such as Zantac also have the same effect. What they do is they decrease the production of gastric acid. But when you look at all the studies, they show that you do decrease esophageal acid, which might be acid reflux, but there's no change in the symptoms compared to a placebo. The studies that have shown that community-acquired pneumonia is more common in babies that are on these reflux treatments than are not. And the risk of gastroenteritis, if you think about it, we have stomach acidity for a reason, and that's because as it goes through into the upper small bowel, it actually suppresses bacterial growth. So adults for instance, who are on Losec have a higher incidence of things like Salmonella and Campylobacter and those things, because the gastric acid is serving a purpose to suppress the growth of those bacteria. So we need to remember that. And the other thing is, in all the studies, if you do nothing, you get spontaneous improvement. So we're not that keen on treating gastro-esophageal reflux unless we think it's really pathological. So a lot of my time in private practice was taking babies off stuff, saying you don't really want your brand new lovely baby on those horrible drugs, do you? But it's quite hard if you're GP. It's really hard to say no to people who come with a preconceived idea, or a midwife. So that's quite a good reference. Hudson's paper from 2012. Acid suppression has no role in the management of the behaviours of crying and spilling. And less than 5% will have an organic problem. And the recent data that I've shown you points to the risk of adverse events. So what do? Well, you try and keep the baby propped up on your chest or on a pillow after feeds. You can use food thickness if it's relevant, but as I said, it's not always. Anti-reflux medication should be way down the bottom of the pyramid. And at that point, you should be thinking, well, if I think it's that bad that I really should be using anti-reflux medication, maybe I should be investigating a bit more formally. So I was just going to say, I think Lindsay's probably covered this, but just to remind you that the average healthy baby at birth is a little bit edematous, carries a little bit of extra fluid. So they're allowed to lose up to 10% in the first few days of life. So that means a 3 kilogram baby can lose 300 grams. So you can go down to 2.7 kilos. The term baby we expect to be back to birth weight in 5 to 7 days, and the preterm baby 10 to 14 days. It's my impression that exclusively breastfed babies might take a little bit longer. I mean, the formula-fed babies, virtually don't lose weight, but they're probably being stuffed. And then my rule of thumb is an ounce a day except on Sundays for weight gains. So that's 180 grams a week. So between 150 and 200 grams a week. And I think we should just relax a little bit about that when we're looking at what's happening. Some people will get a bit over anxious about an only 150 weight gain, but some weeks they'll gain more, some less. Fluids, this is another thing. If you've got a baby in the neonatal unit, and we have all worked in neonatal units, and we learn that you start a baby on 60 mils per kilo for 24 hours. But actually, if you look at the amount of colostrum that's produced in the first 48 hours, it's only about 10 to 20 mils per kilo per day. And that's where that weight loss happens. So just remember that the babies that we're starting on 60 mils per kilo per day on the NICU are either premature, they're growth restricted, or they're sick, or they've got respiratory distress with extra fluid losses. So it's fine not to, top babies up with masses of formula or fluid if they're healthy babies on the postnatal wards or in a birth care. And this is what happens after a few weeks. So this baby was born on the 10th centile for weight and has shifted up to the 50th centile by about 8 weeks. Nobody worries about that, So what we've seen is it got up to the roughly where it's going to be quite close to 5, I've said 8 months, by a few months. But basically, that sort of weight gain says that this baby was probably growth restricted at birth. It was probably a small for dates baby on the 10th centile, and it's come back up to the weight it should have been and the growth should have been. But what about this one? The baby starts on the 97th centile and drifts down to the 25th centile and then maintains that. We worry more, don't we? Yeah. And yet that was probably an infant. Both babies could have been infants of a diabetic, one with impaired placental blood supply and the other one with hyperinsulinism. So you just need to put it into perspective. So if I see a baby like that with that sort of pattern, I think you do need to sit up and take notice. But the chances are this is just a baby who was supposed to be on the 25th centile and his mother grew a bigger baby because she had too much insulin about. So what I do, the first thing you do with that baby is have a look at it. If it looks well covered and just a smallish, compact, nicely covered baby, then I wouldn't worry at all about it. But it's interesting how shifting up is never a problem, but shifting down we worry about. So look at the baby and do their height and weight against each other if you need to demonstrate that. That's all I'm going to say about growth. Crying. Well, this used to be, in the 1960s, the literature was full of articles about infantile colic. And people would say, oh no, the baby's allowed to cry, you must let them cry, otherwise it's not good for their development, all those sorts of things. And they can cry for all these reasons that I put up there. I think the simple thing, my rule of thumb is you should do what feels right to you. If your baby's crying, you want to pick him up and give him a cuddle and find out what's going on. And you can never spoil a baby. That's my theory. So they might be crying because they're hungry, in which case you give them a feed. They might be crying because they wanted attention. And if they want attention, why not give it to them? Why leave them alone in their cot crying? Because they just want a bit of company. And some babies are really pushy like that. They like a lot of company. But you're not going to turn them into a rod for your own back or all those sorts of things that people talk about by just being there for them all the time. That's sort of what you have to be in those first few weeks and months of life.
It's difficult though getting that across to these mothers, whether they're first time mothers, second, third, it's just like, oh, but I've got this to do.
Yeah, exactly.
For the person that wants you, for whatever reason.
Yeah. Well, I think one of the biggest faults of our society is that we encourage mothers. And I'm talking about mothers here because in the first few weeks, they're the key person with their baby. But it's become quite sort of a thing of pride to actually work right up until the day the baby's born. And in fact, most mothers who are running high-powered jobs and organising people and teaching or nursing or doing jobs where they have a lot of timetabling, they just suddenly don't know what to do when you suddenly stop and say, right, you're here now with your baby. And then you have your baby with you the whole day and you don't even have time to have a shower. And you think, what have I done? What sort of a mother am I? I can't cope with this. So I'm a great fan for taking the last 2 months of pregnancy off and getting used to the pace of life. But, I realise that's a luxury for a lot of people. So of course they could, in the old days, have a nappy pin stuck through something and part of their anatomy. They'd be crying because of that, but they might want their nappy changed. They might have reflux, symptomatic reflux. The last one, I think, I've learnt my lesson in sad ways over the years. And I remember one particular baby where the baby was just vomiting and crying and we did everything we could, and eventually the baby actually went to the surgeons, and people thought there was something seriously wrong with this baby, but actually finally things came right, and I saw the baby at about 7 or 8 months of age, and I said to the mother, what do you think changed things for you? And she said, I realised I was depressed and went on to an antidepressive. So I think we should always remember that babies might be crying because they're reflecting maternal mood. The mother's not happy and she doesn't have a partner who's going to take her up and help her with the baby, then maybe we should be thinking that the baby is a bit depressed as well. So I'm just going to concentrate a bit on colic here. I believe that there is a pattern of behaviour that we can call colic. It starts in the 2nd or 3rd week. Why is it not until then? I think it's because that's when you get up to full volume feeds. So you're starting slowly, you're building up, and by about 2 to 3 weeks you're on the maximum volume you're going to be on for a while. They have unsettled, fussy crying behaviour. It starts in the evenings, particularly. In some languages, I think in Indian it's called, the name reflects the fact that it's due to the evening gods. And Wessel defined it, and this definition has been used for a lot of research studies, more than 3 hours a day, more than 3 days a week of crying. Now, these days we wouldn't be happy to allow that, really. So the intensity, duration and frequency is important. The evening pattern resolves at around about 3 months if you're lucky. Every time you see these babies, they're normal on growth and examination, and the parents are far more worried about the colic in terms of its overall effect than the baby seems to be, apart from the crying. And there's no difference between breast and bottle-fed babies in terms of the incidence of colic as described. So the differential diagnosis, huge. Most of which are sort of, you can sort of tell sort of when you look at the baby and examine them and take a history that these are sort of nonsense really. They're not likely to be any of them. But if you're worried about lactose intolerance, then check the stools for sugar. If you take a good history, you'll find out whether reflux disease is a problem. But you have to rule out a strangulated hernia, a fracture, and that's happened to us on the neonatal unit before, a very unsettled baby who turned out to have a fractured femur. Other things like interception or serious infections, but those sorts of things are why you have to examine the baby carefully in colic. How do you manage it? Well, I think a really important thing to do is to examine the baby and have a chat with them and just illustrate to the parent that the baby is actually quite happy with things, thank you very much. I think actually weighing babies for me has always been a bit of a ritual, and I like it because when you're weighing a baby, you're picking them up and you're undressing them and you're panning them, you're talking to them, you're seeing whether they respond to you, and then you're putting them on the scales and you're saying, yeah, look, it's a good weight, we're happy with that. You're measuring their head and everything. And by the time you've finished the weigh, you've virtually examined the baby. You've seen their morrow and their grasp, and they're not floppy. And so I think it's a really good therapeutic way of also mirroring your conversation with the baby, with the parent, which I think is quite helpful. But I also talk about gut maturation, and that is because the gut hasn't ever had to process food in utero, apart from a little bit of liquor. It's like running in a car. You're not going to just be able to just suddenly turn it on and start straight away. So there is a process of slight discomfort as the gut, which is a sort of a flat, tapewormy sort of thing, has to become a round, mobile structure with contents inside it that has to absorb and digest and excrete and contract. And there have been quite good studies about colic showing that babies who have turned out to have more colicky type symptoms have had higher levels of gut motility hormones in their cord blood. So I think that probably explains some of it. But movement, that's why cradles were invented, I'm sure, is fantastic for babies with colic. You put them in the car, go for a ride up on the motorway. Much better on the motorway than a street because you don't have to keep stopping at lights. Yes. At the moment you stop, they start up again. Discuss feeding. I think dummies may sometimes have a role here because they allow the baby to soothe themselves without necessarily feeding them again because they may be being overfed. Dicyclamin, which was Mabental, used to be a fantastic drug in about half the cases, but it's now not available, so we don't use that. And I think the other thing is making sure there's tons of support. Make sure Dad, this is the one time you tell Dad, it's a short time in your life, I know your work's hugely important, but you could just come home at 5 o'clock tonight and for the next week or two. Because, Mum needs a break, and fathers can be great, they can walk in the door, the mother can hand them the baby and go and have a sleep or go and do what she wants to do, but and that's what family and friends are there for as well. And then I usually, if I'm seeing somebody with bad colic, I'll give them a ring in a few days and just see how things are going. That's a good article on infantile colic. Right, that's all I'm going to say about colic. Now the next thing I'm going to talk to is just a little bit about some of the brainwave theory. So the interesting things about babies when they're born, they actually, virtually everything is ready to go. It might not be up to full maturity, like the kidneys only functioning at about a third to a half, really, the glomerular filtration rate that they're going to get to, but they work. But the brain is just, an open book, really. And if you wanted to know just that much, these are the brain growth weight in grams. So at around about 350 to 400 grams at birth. And in the first year of life, it triples in size virtually. And then from 1 year to 3 years, it goes up another third. But then there's not a lot of growth from then on. So what is all that growth? And what is the food for growth? So the food for growth really is in particular nurturing. It's not just, nutrition. And if you really want good examples of this, when I was in my private practice, I used to see these kids from Russia who'd come over at the age of 18 months or so, and I'd measure their heads and they would be small, and so would their weight and their length, but they'd be well nourished, they were in good orphanages. The only thing they didn't have was an attachment relationship with anybody. And within 6 months, the brain, the head size, would cross a centile. It was quite striking. And we know that, if children are failing to thrive, and we think it might be for social reasons, and admitting to the hospital for a few weeks certainly, confirms that. So the other thing that you might be interested to know is that between 34 weeks and term, so the 34 to 40 weeker, the brain increases another third in its size too. So that last 6 weeks of pregnancy is pretty important. So when you're born, you have all your neurons in place. So neuronal migration, formation of neurons and migrating out to where they're going to be in the layers of the brain and the areas of the brain, is virtually complete by 24 weeks. But from 25 weeks on, what happens is that you start to wire and connect these neurons up. And then from 40 weeks on particularly, you also start to myelinate, add a white fatty sheath to these neuronal connections that makes the speed of transmission of an impulse much greater. So you're born with virtually all the neurons sitting there ready to go at term, but you're only about 15% connected. And that other 85% of your connections is going to happen in those first few years of life. Now you do need some connections because you've got to have a heart rate and your brainstem's got to be functioning, you've got to have a blood pressure and a breathing stimulus and heart rate and those sorts of things. We're starting to myelinate some of the big neuronal synapses, and we've started to do a bit of learning in utero. But it's the experiences we have in those first 3 years of life that actually sculpts these connections. They're going to happen. We're programmed genetically to have a whole lot of connections from all of our nerve cells growing out. But which ones we keep and which ones we keep with great intensity are going to depend on our experience. So you can look at that baby with his dad and say, I can sort of see that, you know, he's having a good time, that something's happening there inside his brain, which is that, you know, touch and feel and smell and fun and laughter is what's growing his brain. So we have our senses. So how do you experience the world? Well, you think about it, you know, how does a baby experience the world? He's got these senses, and that's, if you like, he's born into the somatosensory bath that actually enables him to experience the world in many, many different ways. And many of those experiences will be different depending on your gestation. So a baby born at 28 weeks gestation, for instance, is brought out onto a hard, flat surface and is tied down, strapped to things, and, you know, all sorts of different experiences from being in a nice fluid environment where lots of things are happening. So those experiences will mean that he probably does wire himself up a little bit differently. And it's one of the things that we're interested about with the preterm brain, is how they wire themselves up in a way that might be different from a term brain. And they've done these fabulous experiments where they take the shell off quail chicks and incubate the egg with just its membrane, expose it to light, and then hatch it. And they compare the behaviour of those chicks to the behaviour of the chicks that have had a normal shell on incubation. And they behave quite differently. And I think the preterm baby is probably, you know, reflecting some of that as well, because they get light exposure far before they get, you know, other exposures. And the way the senses come online is in a particular order, and it's found that in animals they have to come on in that particular order, and you have to get your experiences in that particular order for them to function in the way we expect babies to function. So if you get your visual before you get your vestibular, then maybe that will change the way you wire yourself up. That might explain why for our preterm babies, when they go home, we say to the parents, your baby is normal, it's neurologically normal, and we think the baby is cognitively normal too on testing at the age of 4. But they go to school and they don't do as well. And the parents come back to us and they say, you said my baby was normal, but they are different from the other children in their class. And we now know that about 50% of the normal preterm babies at follow-up will have a need for special educational assistance. Not seriously necessarily, but it just probably reflects the fact that they have different learning styles because of the way they're wired up. So pruning of those connections is the most important developmental thing that you do in your brain. You start off with a few neurons, not very many wirings, so at birth. At 3 years, this is a histological representation. 3 years, you're massively wired, a conglomeration of wires, and it's probably hard for the brain to make much sense of that. So slowly, you retain the connections that you're using a lot with frequency. You myelinate those ones with intensity and frequency, and you drop out the ones that you're not using. So it's a use it or lose it phenomenon. Just to mention the microbiome, those of you who know Tosh Stanley know that this is one of his favourite topics. So we are born, actually we now know that probably we are born with bacteria, and you know the liquor has bacteria in it anyway, so it's not totally sterile the way we once thought. But our microbiome are the bacteria that live in and on and around us. So each of us, have about 1.5 to 2 kilograms of bacteria of our body weight is bacteria. And there are more cells in our microbiome that we're carrying on and in us than there are cells in our own body. So we're a symbiotic unit with our bacteria. And that we pick up most of our gut microbiome by being born through the birth canal. So you can imagine that after caesarean delivery, you'll have a different microbiome. You'll get there, you'll develop the normal microbiome, but it'll be a bit slower to come. And of course, the microbiome is quite important because it may protect us against pathologic bacteria. Breastfeeding is important because it's a probiotic-prebiotic combination. And the other thing is that the oligosaccharides in breast milk really promote growth of the microbiome. Antibiotics obviously alter the microbiome. So why am I telling you this when I'm talking about brain development? Well, it just so happens that we think now an awful lot of brain development depends on the conversations that our microbiome have with our developing brain. Via the vagal nerve and the networks to and within the brain, but also via circulating cells that are primed in the gut and then travel to the brain and tell it things. I'm not sure what these conversations are about, but it seems to be important. And then the bacteria also produce metabolites, which might be like cytokines as well, that go off the brain. And so people are getting really interested in this, because if you actually disturb the microbiome too much, you may increase your risk of things like autism. And we know that, for instance, preterm babies in the neonatal unit that are born extremely preterm, they virtually live in an environment of antibiotics. And we sterilise everything, of course. We also know that autism has a higher incidence in the preterm population than in the general population. So we're now starting to get much more careful about, if we think a baby might have an infection, we culture them, we start the antibiotics, but we stop at 36 hours once we know the cultures are clear. So it's starting to change our behaviour. Right, I'm going to move on to something else, also to do with brain development. I just want to talk about the fact that the brain development is not linear. You go up a little patch and then you have a plateau and then you go up again. And there are certain points in time at which our brain is primed to take on this information, and if it doesn't get it, it maybe never gets it. It's a bit like the baby who, if you never feed a baby, let a baby suck via a teat of some sort, or a nipple, you go beyond 6 months to a year, then they'll probably never be able to do it, because the whole of their brain and their systems have been bypassed, if you like. So it's important to make sure that we give these babies a chance to have their developmental skills. And this is some of the sensitive periods. Another one is obviously binocular vision. If a child has a squint, so that one eye's looking that way, and so every time they look in a certain direction they have double vision, what happens, the brain just switches off the vision in the bad eye. And if it stays switched off for too long, then even though you correct the squint, you won't correct the ability to have binocular vision. And that's somewhere about 5 or 6 years of age for squints. For cataracts and not getting any light onto the retina at all, it may only be a few weeks. I want to talk about social attachment, which, as you can see there, happens somewhere between 1 and between 0 and 2, but mostly around about 6 or 7 months. Because attachment seems to be a really important part of our development, and it's why we talk about the importance of having 1 or 2 primary caregivers. It's why we think that babies in orphanages miss out on certain things and their brains don't develop in the same way. So the attachment is this process whereby there's a relationship between the caregiver and the baby, which is mutually beneficial and enjoyable. And it happens just through the normal everyday things you're doing with the baby, like changing their nappy or feeding them or talking to them or singing to them. But it seems to promote, as you can see with that baby there, some sort of ability to connect with another human being. And I don't know whether you know, but if you look at babies, and the most reassuring thing you can do, even with a newborn, but certainly within a few weeks, is when you look at a baby, if they give you a good hard stare, you know that there's somebody upstairs. And I think that's, it's not just a simple observation, it is quite important. So the earliest attachments we make are usually by about 6 or 7 months, and that makes sense if you think about stranger anxiety, because babies, by the time they get to 6 or 7 months, they start to get a little bit funny if it's not their mum or dad or their caregiver around them. Virtually all infants become attached they're only attached to a few persons, but it doesn't have to be just the mum or the dad. These selective attachments are derived from social interactions with the people, and there are organisational changes in the brain and in the behaviours as a result of that. This is a still face experiment, and I can't get that to work on this computer, but essentially this mother is the still face experiment shows you this mother talking to her child, and the child's face lighting up and everything like that, and they're having this great conversation. Then the mother is asked to just put a still face on, and the baby starts going, it's like, come on, watch me, I want to do something, and it gets more and more disorganised behaviour, and then it starts to cry. The moment she starts talking to it and calms him down again, the baby's back focused on her face and really enjoying life again. And it's a really good example of how these babies really do need this social interaction to develop their social being. So secure attachments, which are can be defined, and I'm not going to go into that, but basically you've got a secure attachment if you have a good relationship with a primary caregiver, and you can recall that in your own life. But these babies are much more regulated than babies who don't have secure attachments, and it's associated with these sort of positive things in their early life. And secure attachment gives you resilience, so that if things go badly in your life and you've had a secure attachment, you may be able to deal with it. Maybe the reason why some children we see who we think have had a terrible first few years of life seem to come out of it and be okay. So I'll let you read that, but essentially these are kids that have hope that difficult things can be overcome by perseverance and hard work. And I think this kid is great, because you look at him and he's got a relationship with whoever's behind the camera, and he's basically, he's a securely attached child, even if he does need his nose wiping. So if you're going to wire your brain up according to these experiences, they need to be positive experiences. And negative experiences may mean that you wire your brain up in a way that primes you for negativity and an unhappy life. And there's plenty of examples of that. And you can't learn if you're constantly having negative things. So if a child's constantly abused, spoken down to, put down, exposed to family violence, all of those things, then they're going to wire themselves up in a way that isn't going to be, if you like, touchy-feely positive. You need to have some experiences. This child was actually found by his grandfather because his mother, who was a drug addict, kept him in a darkened room all day on his own while she went out to work. And negative experiences often operate in terms of the effect on both the brain and the body by stress. And the stress is mediated via excess cortisol. And so this fight or flight stuff that goes where you're constantly in that state because you're exposed to family violence, then you're going to affect your brain development in some ways. And one of them, a little bit of stress is important. We need stress to actually make us stimulate, to get up and talk, to go and give lectures, or to do something that's a wee bit outside of our comfort zone. But too much may be detrimental because we secrete so much cortisol that it starts to switch off other things in our body. These are schematic representations of the brain. So the human is sort of the way it is because we have a huge cortex. That's our thinking part of our brain, particularly the prefrontal cortex and frontal cortex, where we make reasons, decisions, and we can be rational human beings. The limbic system is all our appetites, essentially, basically sex and those sorts of things, feelings. The midbrain is the area where we sort of control quite a lot of the other stuff, and the brainstem is what just makes us tick in terms of heart rate, blood pressure and stuff. When you're exposed to a lot of stress, it seems that you go down the hierarchy and you start to act more in a more sort of lizard type way, if you like. And I think a good example of this is people who become demented start to become disinhibited because they lose the cortical control of their thinking. So a lot of stress on a person's will make them regress down to so that the cortical responses are probably the least important. We worry about that.